Hey folks, Scott Weingart here, and this is an EMCrit Wee. This is one of the iterations of cardiovascular EMCrit, which of course means we're being joined by the brilliant Trina Augustin, editor of all things cardiovascular EMCrit. Today marks the start of a new occasional series, the MCS Minute, the Mechanical Circulatory Support Minute. Trina is obsessed with all things mechanical circulatory support. If in the next 10 years she is not the foremost authority on all things mechanical circulatory support, I will be incredibly surprised. This is an obsession for her. Now, you might be saying, I'm out. Done. I don't have ECMO at my shop. I don't deal with MCS in any regard, so I'm not going to listen to this. Don't do that on this one, at least. I will warn you on future iterations if they are really only specific to ECMO and MCS type stuff, because the physiology we're going to discuss is directly applicable to all of your non-MCS patients. You must listen to this. You must understand this. And we're going to discuss this as using ECMO as the lens. But honestly, this is exactly what you need to understand on any ARDS patient who you want to discover. Can I tolerate a lower oxygen saturation? Like if they're 86, is that going to be a problem? Is it going to be okay? You need to understand all this. In a patient with a severe shock state, are they managing despite the low blood pressure or not? Decreased cardiac output, is that okay? The essence of what we're talking about today is the way you make that determination. Now, there is a show note support for this episode you could find on emcrit.org. But then also linked there, you will find a blog post by none other than, friend of the show, partner in all things EMCrit, Josh Farkas, discussing this same situation in a patient with ARDS. So now you could relate this through the show notes of this episode through mechanical circulatory support. Then you could go to Josh's and hear all of the messages we're going to discuss in the venue of a ARDS patient. So this is really applicable. This is just basic physiology. You don't need to ever touch an ECMO pump in order to make this relevant. So do listen. It's good stuff. Let's get into it. All right. So welcome back to the show, Trina. Welcome to Cardiovascular EMCrit, of which you are the editor. And you told me you wanted to do a new series, so we'll be interspersing these throughout the year, of mechanical circulatory support minutes. Tell me what we're going to be accomplishing here.
First of all, it's amazing to be back after taking a little hiatus. I definitely missed it, so it's lovely to be back with you. But yes, I feel pretty passionately about MCS, as we both know. And I'm super excited. I was thinking on rounds the other day as we were rounding and talking about all of our ECMO patients, how frequently little questions come up related to their management. And I know you and I have discussed me doing a cardiovascular intensivist series, which I'm hoping to roll out this fall/winter as well. But I also want to do this, what we call the MCS minutes, or mechanical circulatory support minutes, where we tackle quick questions that can come up on rounds with the goal of coming with high yield concepts that we can talk about in 10 minutes or less that will hopefully help people on their daily management of these patients.
I love it. I can't wait. Now, we're going to do today the DO2 to VO2 ratio and how that relates specifically to ECMO. So tell me how this works.
First of all, I do want to talk about it relating to VV and VA ECMO because it's going to be a little different for both of them. But at the bare basics, I always think of ECMO as a consult for inadequate DO2 or inadequate oxygen delivery. Now, if you're a critic out there, you can say there are occasions when I'm going to consult for ECMO for pure hypercarbic respiratory failure. That's true. As someone who's cannulated a fair amount, I will tell you that it's very rarely that I have a pure hypercarbic respiratory failure without a problem with oxygen delivery. But it can happen. But for the most part, when you are consulting for VV or VA ECMO, what you're really telling me is that you have inadequate oxygen delivery. VA ECMO, it's probably in the form of inadequate cardiac output, hence inadequate oxygen delivery. VV ECMO, typically you're going to have that severe hypoxic respiratory failure with inadequate pulse oximetry or SaO2 and inadequate PaO2, and thus an inadequate oxygen content, giving you inadequate oxygen delivery.
Now, look, people might be stopping listening if they don't deal with mechanical circulatory support at this point, and they shouldn't, because this is just as relevant for a patient in severe ARDS who's not going on pump. And in fact, Josh has a wonderful post discussing that very issue. So keep listening. The physiology here is directly applicable to how to know if you could tolerate lower than normal oxygen saturations. Because in some cases, that's devastating. In some cases, the patients will do just fine with an 83% sat if their uptake is not particularly high. So let's talk it through. So where should we start on this?
Perfect. So I think we should first define the concepts. I think for some of us, we are very used to talking about this, but for some people, this might be a new concept. So when we're talking a DO2 to VO2 ratio, basically what we're talking about is the ratio of oxygen delivery to oxygen consumption. And specifically, oxygen delivery is your cardiac output times your oxygen content. On ECMO, we're classically thinking of that cardiac output as a combination of the ECMO flow plus their native cardiac output. Get the little nuance when you're talking VV versus VA, but just simplistically thinking of it as your ECMO flow plus your native cardiac output. And your oxygen content is made up of multiple things. But the important factors in that is your hemoglobin, your oxygen saturation, and then your VO2 can come into that, but we all know that there's often not as much oxygen dissolved in blood, and normally we can consider that negligible, except for those rare situations where you have a VO2 of 500 on ECMO, you might have a little bit more oxygen delivery there. So that's oxygen delivery. We're comparing that to your oxygen consumption. And oxygen consumption is looked at as your cardiac output times the difference between your arterial oxygen content minus your venous oxygen content. And what we want is we want that delivery to be approximately, in a perfect world, 5 times what our consumption is. For you and I sitting here talking, that is physiologically probably where we are at. But the problem becomes when patients' oxygen delivery to consumption ratio falls to that critical kind of physiological precipice where their DO2 to VO2 ratio is about 2 to 1. And that's when you are going to see resultant lactic acidosis, you're going to have cardiovascular collapse, multi-organ failure. And that is when we really want to try to prevent.
All right. So that was a fantastic explanation. And just to put this in slightly different terms that might click people into what we're talking about here. Normally, your hemoglobins go round and round, and if your lungs are working properly, they get saturated with 4 oxygen molecules. And then they hit the tissue, and the tissue says, I want some oxygen, and they take off 1. And then it goes back to your lungs at around 75% saturated, right in that neighborhood, 70% thereabouts. And then your lungs put back on 1 oxygen. Doesn't take much work for your lungs. Great. Okay. And so now we have a patient who is in a shock state. And the reason they're in a shock state, just as you say, is their delivery is not enough. It could be inadequate oxygenation at the level of the lungs. It could be inadequate cardiac output. And now the hemoglobin's going past. Let's say the lungs are working in this example. It's 4 oxygens on there, 100% saturated. But now your tissues, they're not seeing enough of those hemoglobins coming around. They take off 2. Now it comes back to the lungs at 50% saturation. So now you have a consumption to delivery that's a very different ratio. And this should make you worried. 50% on the venous side, big problem. So how do you fix that? You send them around quicker, tissues take off less. Or same thing, maybe your lungs are not working great. And so now, instead of 100% saturated, they're only 75% saturated. Okay, the tissues still want their same thing. Brings that down to, again, to the 50% bad. So this is a patient who you might see having end organ failure because their lungs are not able to do the work. Or you mentioned the VA example. It's a patient whose lungs might be working, but they're not getting enough cardiac output to send enough hemoglobins around. But either way, when you see on the venous side a saturation that's markedly less, and you're putting it in terms of a ratio, which makes even more sense, that's a problem, and it's a problem we have to fix. Does that jive with what you're saying, Katrina?
I love it. Absolutely.
All right. So you've explained this very nicely. Where do we go next?
So I think the next question becomes, how do we fix this? So if we are seeing this, how do we fix it? And first of all, how do we recognize it? Because many times people are like, well, do I have to do all this complex math? And especially when you're dealing with complex critical patients, none of us have time to do math. I think we've established that in medicine. Doing math in a critical situation doesn't work out well. So what we can basically do is follow that venous oxygen saturation to give us an estimate of what our oxygen delivery to consumption ratio is. Like you're talking about the percentage of oxygen taken off of that hemoglobin. And there's a beautiful graph in the post that I would highly recommend people refer to that Dr. Bartlett has in his paper, and it's fantastic. But basically, you can use your oxygen saturation. And if the patient is on ECMO, we classically are using this pre-oxygenator saturation, which is the equivalent of an SCVO2. And you're looking at that. If you are providing adequate oxygen delivery, say at a DO2 to VO2 ratio of 3-to-1 or higher, your oxygen saturation should be around that 66 to 75%, telling you that you are actually delivering plenty of oxygen for their extraction. On the other hand, if you suddenly have a SCVO2 or pre-oxygenator saturation of 50%, we are at that physiological precipice that you mentioned, where you are removing so much of that oxygen because they are having inadequate oxygen delivery, whether it's secondary to inadequate cardiac output, inadequate hemoglobin, severe anemia, or severe hypoxemia. So once you see that low oxygen saturation, then the question becomes, how do I fix this?
Yeah, so let me make sure people really understand. So now, in an ideal world, it wouldn't be a central venous oxygen saturation from a neck central line. It would be a pulmonary artery catheter, because now you're getting everything, not just the upper body from the SVC, but also the lower body. Now, most of the time, people are not getting PA catheters outside of the cardiovascular ICU. I personally feel we've gone too far on that. All of the studies that destroyed the validity of the PA catheter was predicate on the pulmonary capillary wedge pressure, basically a useless number to my regard. But the mixed venous oxygen saturation, to my understanding, has never been truly evaluated for its clinical utility. It was just swept under the auspices of the PA catheter's garbage for assessing fluid responsiveness and stuff like that. I wish, Trina, we took this outside of the CTICU and actually had this in real places. I don't know what your opinion is. I'll hear about that in a second. But that would be the ideal. Now, you can get a surrogate of that with a central venous oxygen saturation off a neck central line. Not as good. Now, you mentioned an additional surrogacy coming from the pre-oxygenator blood gas. Now, that's nice because, in essence, that is a mixture of most of the body's blood. Now, what would you say to a person who is using exactly what you're saying to determine, does the patient need VV ECMO? Will there be any problems from using a CVO2 rather than a true mixed venous oxygen saturation?
So I love that question. For the most part, most people are going to be using an SCVO2 because we really have moved away from PA catheters. Whether that's a good or a bad thing, I'm with you. I have some mixed feelings on that. But I will tell you that for the most part, it is okay to use that SCVO2 as an approximant of your SVO2. Normally, there is not that much of a difference that you really should not be guided in the wrong direction. And I'm assuming that you are getting that SCVO2 from a reliable source. You know, there's times when you see those central lines that are sitting at some crazy place, maybe not the best one to pull it off of. But if you are really sitting at that nice kind of cable atrial junction, you should be great to use that as an approximant.
Yeah, I'll go a step further and say, like, we were used to being told 20 years ago, you cannot have a central line tip in the atrium. That's really bad. It's going to erode through the heart. It's not the case anymore. Having an RA tip of your central line, especially for something like this, is actually fantastic, because then the central venous oxygen saturation you pull is not a central venous oxygen saturation. It's actually a pretty nice blend of the entire body in that RA. So if you have a deep line, then this becomes even more accurate. But I agree with you. I think as a global surrogate for the big stuff we're asking ourselves of, do we need an ECMO consult or not? Yeah, it's pretty good.
And Scott, I'll tell you this, one of the reasons I love the pre-oxygenator sat is especially on VA ECMO, when you have a nice multi-stage bicable drain sitting in there, you're really pulling blood from your SVC, your RA, your IBC. You are getting a pretty good approximate, I think, of that PA. And I actually need to do this kind of on my own because I'm wanting to actually start pulling, because I have a lot of patients that sit there with PA catheters in. I really do need to start comparing the saturations because I think it'll be very interesting seeing really how different they are.
That would be brilliant. That would be a great study to see. All right. So now, do they have to calculate the ratio, or could they just look at the one number of what that central venous or pre-oxygenator sat is? Do they need a ratio?
So I love it. The down and dirty is no. You can do it without the ratio. You can follow that number, and specifically the trend. We all know in medicine, one number is not a great thing, but it's about that trend. So I find it really important to follow that SCVO2 trend. So whether you're someone who's just calibrating your ECMO pumps and actually following it on the pump, or you're pulling regular pre-oxygenator gases, following that trend is going to give you a really good idea of, is my oxygen delivery adequate? Or do I need to do an intervention to increase it?
All right. Okay, so let's talk about those interventions. So now you have central venous oxygen or pre-oxygenator sat of 50% or less than the 3-to-1 ratio. You're getting scared here. What do you do?
Oh, this is the fun part. So now you get to do some fun managing. So the first thing that I'll reach for the most part is going up on my ECMO flows. So when you're talking VV versus VA ECMO, with both of them going up on your ECMO flows, you're increasing your oxygen delivery, but it's in a slightly different mechanism. So take VV ECMO, for instance, first. So in VV ECMO, we all know all of this ECMO flow that's coming back to the heart is going to be going through the heart. So say you have a patient that has a total native cardiac output of 8 liters. Say my ECMO flow is running 4 liters. And so I'm capturing 50% of that flow. If the 4 liters going through the ECMO circuit is saturated with 100% FiO2, PaO2 is, nicely elevated. On the other hand, my 4 liters going through this patient's native lungs that has severe ARDS is getting very little oxygen. Say it has a saturation of 60%. My combined oxygenation saturation might be around 80% with those combined areas. If you go up on your ECMO flows, you are going to capture more of their total cardiac output. Their total cardiac output is still going to be the same, but you are capturing more of their total cardiac output going through the ECMO circuit. Hence, you are delivering more highly oxygenated blood. So you are increasing their oxygen content and thus their oxygen delivery.
Let's lock that in. All right. So the idea is, in an ideal world, we'd be taking all of the venous return. We'd steal it all from the heart because obviously the reason they're on VV ECMO is their lungs are not doing the job it should be. And now that's hard sometimes. Now, if we could, with the combination of the two, get to a good place, great. If we can't, we need more. And that might be turning up the flow, but the entire conglomeration of where the cannula sits, how big the cannula is, it might not be enough. And sometimes we even have to go further. Sometimes we have to have a dual drainage cannulation. Sometimes there's case reports everywhere. I don't know how many of these you've done, but you actually need a second pump to actually grab more of the patient's venous return so it doesn't go to their heart. But one way or another, you need to get enough of it so that the perfectly oxygenated blood coming out of the ECMO circuit is enough to make the tissues receive adequate oxygen, as demonstrated by an SCVO2 or a pre-membrane saturation of greater than the 50% we are at the point of this misery we're dealing with right now. What number makes you happy in terms of absolutes? We talked about ratios that would make you happy, 5-to-1. Are you using 65? Are you using 70? What saturation is good for you, Trina?
I'm aiming for 65. I find that gives me pretty close to my 3-to-1 ratio, and most patients are doing fantastic with that. Technically, I find clinically, I can go a little lower than that and have no problem. But if I target 65, that way if I walk away, get busy, and it ends up being a little lower, the patient starts shivering, doing something with increased oxygen extraction, I have a little buffer.
All right, sounds good. And we should say, and I don't know if you were going to mention it later, but let's mention it now. You can affect the consumption side of things as well outside of the ECMO circuit. If the patient is hypermetabolic because of a fever or something along those lines, then taking that away is also going to make your ratios and mixed venous surrogates better because the patient is consuming less oxygen.
Absolutely. Those are the times that I'm treating fever, I'm treating the shivering. If it is someone that's intubated and still heavily sedated, you might have to consider your sedation, paralysis, even cooling. Now, I'm someone who likes to do a lot of awake ECMO, so I'm trying to stay away from a lot of those things. But definitely doing anything you can to decrease their metabolic demand is imperative at that point.
All right, let's talk about VA and how it differs.
Awesome. So VA ECMO, you can also increase your flows. Here, you're going to basically be increasing their total overall cardiac output. And so in that way, you're going to increase their oxygen delivery. Clearly, if you have increased flows, there's going to be a component of increased oxygen content, but I primarily think of it more as an increased oxygen delivery secondary to the increased cardiac output.
All right. Anything more you want to say about VA before we go on to the controversial topic of hemoglobin?
I think we're ready to dive right in. Let's do it.
Yeah, I don't even know what to do here, Trina, because this is such just a hot topic for many of people in cardiovascular care in general, but specifically in ECMO. Now, if I look at that oxygen delivery formula you sent me, it would seem intuitive that I would just want to bump up that hemoglobin as high as possible, like maybe even transfusing them to normal or 15. But we don't do that. Why don't we do that? The formula says we should.
Other than that we're worried what people are going to think? I'm just kidding.
Yeah.
I think this is interesting because most of us have been trained and practiced in this era where it's all about we're trying to be conservative in our blood transfusions, and we all are aware of all the downsides, taco, trolley, all of these different things. And we've had a lot of studies that make us question Whether transfusing to higher levels is good, bad, I find that the data becomes more and more mixed the longer I'm practicing. And specifically in cardiovascular critical care, this is a hot topic. I think all of us who have worked with the surgeons are very used to being requested to push the hemoglobin to 10. Maybe there's a little data in some aortic cases for aortic perfusion, but really there's not great data anywhere. And there's definitely not great data in ECMO, ever. If you look at that equation like we talked about, and if you look at that fantastic graph that I put in the actual post from Bartlett, you can see that for the patient that has a saturation of 100% and that VO2 of 150, their oxygen content when they have a hemoglobin of 7.5 compared to 15 is double. And even, I think, almost cooler, if you look right underneath there, I actually attached 2 blood gases from one of my patients that I cannulated a couple weeks ago. On day 1, they had a beautiful hemoglobin of 13. On day 6, they had a hemoglobin of somewhere around the 8 region. If you look, their pulse ox and VO2 are almost identical on those 2 gases. And yet, their oxygen content is drastically different. And yes, I do work at an institution that has a lot of resources and that prints out an oxygen content for me. But it is a really great tool to see the huge difference in oxygen delivery that you can affect with just increasing your hemoglobin. But that brings up the controversial question of what's the right hemoglobin?
Hey, folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members-only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening. So are you going to answer us, Trina?
Oh, I wish I had an answer. I think it's interesting because also hedges on this. Their most recent guidelines that I'm aware of talk about a range between 7 and 9. Clearly, there's a difference. If you have a patient in front of you that is bleeding on ECMO, you're going to transfuse to a higher level. If you have a patient that is pre-transplant that you want to make sure that they don't have sensitization, I might keep them at a little lower level. What I will tell you is clinically, my goal tends to sit between that 7 and 9 range. Now, if it is a transplant patient, I am a little bit more conservative versus on the other hand, if I have a patient that I am really struggling and my pre-oxygenator gas is sitting at 50%, I am maximized on my flows, I really don't have much else to do, I might push their hemoglobin higher. Do I have great data for it? No, but you will watch that pre-oxygenator saturation go up clinically. And I think at the patient level, you are seeing a difference.
There's 2 things that come to mind, and I agree with you. I don't have a clean answer. First of all, there is a level of hemoglobin that starts giving viscosity hits to your flow on the pump. Now, I don't know where that level is. Even in the range that they're hedging on, 7 to 9, that's still very conservative to where we used to be. In early days of ECMO, they were transfusing to a hemoglobin of 15. And I think 15 probably is a viscosity difference. Now, the 7 to 9 seems very reasonable. What I would ask to anyone who I pose these questions to is, all right, we know the downsides are immunosuppressant effects, all sorts of inflammatory effects from having foreign blood. But there is, in the near future, the imminent potential for artificial hemoglobin that won't have these issues. And then it'll become a real question of when there's no longer any downsides to immunomodulatory effects and inflammation, then what's the number? Because now we're talking pure physiology versus a balance of benefit and downside. And I just wonder, will we be transfusing to the hemoglobin of 15 again when there are no downsides to it? I don't know. Do you have any inkling, Trina, or are you still just waiting for data to emerge?
I am doing the same thing as you, waiting for that data to emerge. I think that I would say over the last year, I have found myself pushing to a little higher hemoglobins than I was previously. And it's definitely patient dependent, but I definitely agree with you that I think once we are able to negate some of those other things that come with blood transfusion, if we could get around that, I think a lot of us would push hemoglobin a little higher. because I personally have not seen an issue with increased viscosity in hemoglobins that we're talking in that range.
Yep.
Now, I don't normally push people to a hemoglobin of 15. I do foresee that could be an area where you might actually see a difference. I think it'll be interesting to see the data unravel in the next couple of years.
Absolutely. All right. What have we missed that you want to get across to the folks listening?
One other thing is for kind of the intuitive listener who is listening to this and then also looks at the post, they might say your SaO2 is also part of that O2 content and thus your O2 delivery. Can I just fix that and get their oxygen delivery to be better? The reason I want to bring this up is I want to caution people a little bit because I find that some people do try to do this. It's those patients that we have on VV-ECMO and I walk in the room and they're suddenly on ventilator settings that are harmful and definitely not lung protective. And one of the things that I would caution is classically, especially on your VV-ECMO patients, you're really going to have a hard time optimizing their oxygen delivery by increasing their pulse oximetry. And frequently that is because you really want to make sure that you are still maintaining lung protective ventilatory settings. Remember, one of the biggest goals of ECMO and putting them on is to allow you to give adequate oxygen delivery while preventing harmful interventions like harmful ventilator settings or high doses of vasopressors, inotropes when you're talking VA ECMO. Other things that people might say is, can I just add another oxygenator to try to increase their oxygen saturation? Sure, you can try it, but it's normally not very effective. Most of these oxygenators are actually flow limited. And there's a maximum flow that you can have going through this oxygenator to at a point where when the blood is now coming out of your oxygenator, it is no longer going to be fully oxygenated. So adding an extra oxygenator really doesn't give you a lot of bang for your buck. And then one other thing, a pet peeve of mine, full disclosure, is when I come on in the morning and I have a VV ECMO patient that just received a ton of beta blockers overnight. Mm-hmm. And the reason that I bring this up is I'm not saying that this is a black and white issue and that there is never a right moment for this. But think back to what we talked about. When you have a patient on VV ECMO, picture them with a total cardiac output of, say, 10 liters, and you are capturing 5 liters of that going through your circuit. What most people think is if I give a beta blocker, I can decrease that shunt fraction, meaning the fraction of the flow that is escaping coming through my ECMO flows. So if I can drop their cardiac output to 8 liters, I will capture more of their blood volume and hopefully have more oxygenated cardiac output and my pulse ox will look better. But what you have to remember is what you're doing is overall decreasing their total cardiac output. And if you look at your oxygen delivery equation, which is cardiac output times oxygen content, even if you're bringing your pulse ox up a little bit, if your cardiac output is taking a big hit, you are overall decreasing their oxygen delivery instead of increasing it. Now, there might be a rare situation I find on some of my awake ECMO patients that are young, that have this massive sympathetic response. They're tachycardic to 120s, 130s. They're hypertensive. Their cardiac output is they have hyperdynamic EF. Their output's probably 10, 11 liters. Maybe there is an occasion to give beta blockers, but there I'm doing it to decrease their metabolic demand, not necessarily to just increase that pulse ox. It's all about decreasing their oxygen consumption. So just be aware. One of the things I caution people is just don't have that be a knee-jerk reaction that I see a pulse ox of 80% and on goes the beta blockers.
I love that. It's funny because the rest settings on the ventilator for VV ECMO is another source of controversy in the literature. I was trained in a place where APRV was predominant, and we're really experienced at evaluating X-ray for recruitment and deciding, because all we want, I don't care about CO2, I don't care about ventilation, because the pump is so much more effective at that than I could do anything with those lungs. All I want is a recruited lung and then just leave them to sit there. And, my pet peeve is when I check on a patient and their settings are such that their lung is completely de-recruited and it's not going to heal. The machine's a temporizing measure, but I want them off. And so what is your go-to lung rest settings while a patient's on VV?
I love this. I feel like this is a daily conversation with the fellows when we round on these patients. So I was trained where typically when I first started this, I remember people saying, we just put them on rest settings. Everyone goes on pressure control with a pressure support of 10 over a PEEP of 10. We'll put them on a respiratory rate of 10, low FiO2, and just let them sit there. And then I watched all of these people massively de-recruit. Their lungs become fibrotic, and we were heading toward lung transplant over and over. And I thought, no, this is definitely not, I don't think, the right answer. And so my practice has drastically changed, I would say, over the last year and a half. to the point where I still set a very low respiratory rate. So I want to decrease their mechanical power. So low respiratory rate, 100%. Low FiO2, absolutely. Low driving pressure, absolutely. So my driving pressure, I try to maintain definitely under 14. I tend to sit somewhere around 10. But the PEEP is the area that I am hugely variable. I actually will do a PEEP titration to find their optimal PEEP. What I have found is that especially with a lot of these patients with a larger BMI, a PEEP of 10 is completely inadequate to prevent them from completely de-recruiting, ending up with atelectatrauma, increased biotrauma, and ending up with fibrosis. So I tend to be sitting at a much higher PEEP. It is variable based on the patient, their lung physiology. But with all of these patients, I am doing multiple measures to try to figure out what their optimal PEEP is. And once in a while, we'll even check transpulmonary pressures and drop an esophageal balloon on these patients.
Yeah, that's exactly right. That totally fits. Yeah, no, it's funny because people don't understand. If you get a 500-pound patient, a PEEP of 10 is way into the negatives. They're so far from being even at ZEEP, the equivalent of it, just from their chest wall, that you're really just destroying their lungs. These patients start at 24. That's their 0 point. And then anything you add on top of that is when they start getting positive pressure from a transalveolar perspective. Yep, I can't agree more. All right, anything we missed or you want to add, Trina, before we say goodbye?
No, I love it. I think just for the listeners to take on, remember that I think of an ECMO consult as a consult for inadequate oxygen delivery. Remember, you're targeting that ECMO, that DO2 to VO2 ratio in ECMO of 3:1. So I'm targeting that saturation of about 65% when we're talking a pre-oxygenator saturation. And also, remember to use your ECMO. The goal of ECMO is to provide adequate oxygen delivery while avoiding harmful ventilator settings and harmful inotropes and vasopressors. So I love ECMO, but I want to make sure that we're all using it aggressively in that right way.
Perfect. All right. I can't wait for more of these MCS minutes. We went a little bit over our projected time, but that's because this is so much fun to talk about. And hopefully it will be fun for the listeners as well. So I can't thank you enough, Trina, and I can't wait to talk to you again.
Awesome. Thanks so much, Scott. It was wonderful being here.